Okay, good evening, everyone. And on behalf of the Education and Professional Development Committee, you all tonight to the second part of our critical care webinar series. And tonight we are thrilled to have two great speakers for you, Dr. Samantha Moore and Dr. Kaitlin Landolf. To start out with, we have Dr. Samantha Moore, who has been a clinical assistant professor at St. John's University College of Pharmacy and Health Sciences in Queens, New York since 2016. She received her PharmD from MCPHS, followed by a PGY1 residency at Beth Israel Deaconess Medical Center and a PGY2 residency in critical care at New York Presbyterian Hospital, and is a board-certified critical care pharmacist. Dr. Moore's practice site is in the Trauma and Surgical Intensive Care Unit at Bellevue Hospital Center, a level 1 trauma center in New York City. She has expertise in managing acute pain in complex critically ill patients and is involved in several research projects evaluating opioid use in the trauma population and the use of multimodal analgesia in critically ill surgical patients. And today she is going to be presenting "It Doesn't Have to Be Painful: Optimizing Analgesia in Critically Ill Patients." Before we get started, I'd like to share a few quick points. For those of you that have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist you to a resolution. And for those of you that have questions that you would like to direct towards the speaker, please use the chat option as well. And this code for each session will be provided at the end of each speaker's talk. And with that, I will turn it over to you, Dr. Moore.
Thank you very much for that introduction. So I just want to start off, I have no financial disclosures or conflicts of interest. So the objectives for today's presentation, by the end, you should be able to identify negative outcomes associated with uncontrolled pain in critically ill adult patients, describe a validated and evidence-based assessment method for detecting pain in critically ill adult patients who are unable to communicate, and finally, be able to recommend an appropriate analgesic regimen incorporating multimodal agents for a critically ill patient. So pain. Pain is defined by the International Association for the Study of Pain, also known as IASP, as an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage, or described in terms of such damage. And unfortunately, in the ICU, the occurrence of pain is ubiquitous. Studies suggest that pain occurs in anywhere from 50 to 80% of all patients during their ICU stay. And this includes patients in both surgical and medical ICUs. Critically ill patients experience pain at rest, with procedures, and after major surgeries. And one of the statistics that, has been around for a while, it's an older study, but that really always stands out to me, is from an observational study that found that patients and families of patients report pain to be the most distressing experience from their time in the ICU. So, we've known for many years that pain is far too common an occurrence for critically ill patients. The detection of pain in individual patients and adequate treatment really still remains very complex. It's truly pain is a subjective experience, and many of our patients in the ICU can't communicate for multiple reasons. Additionally, they often have multiple sources of pain, including underlying medical conditions or chronic pain. And really, there's always the fine balancing act between, adequately managing a patient's pain as well as avoiding adverse effects from analgesics, which a lot of times our patients who are critically ill are at an even greater risk of experiencing. However, as pharmacists, we have expertise in analgesics and, our knowledge of critical illness. We can truly help make a difference in patient care through improving outcomes, while still prioritizing safety and ensuring patient comfort whenever possible. So, as we just said, patients can experience pain at any time during their ICU stay, and any patient can. But several observational studies have found that certain patients tend to be at a greater risk of experiencing pain. So patients, who are most likely to experience pain and more severe pain at rest in the ICU tend to be younger, have a greater number of comorbidities, more likely to have a history of anxiety or depression. And in addition, patients who report experiencing basically a greater intensity of pain for a greater period of time tend to, report, have greater pain. Also, patients who are in the ICU for longer tend to experience, not surprisingly, more patients who are in the ICU for shorter lengths of stay. And finally, in terms of procedural pain, not surprisingly, the type of procedures associated with pain intensity, as well as surgery and trauma patients to be at greater risk, as well as younger patients again, and female sex. So why do we care, so much about pain in the ICU that we're having, 2 talks tonight on it, or at least related to pain? So, first and foremost, as clinicians, it's really our responsibility to help patients and prevent any unnecessary suffering. This doesn't mean that we necessarily can or even should completely eradicate any pain that the patient is experiencing. Like I said, we are especially poised as pharmacists to use our knowledge to ensure that no patient is at least experiencing extreme and unnecessary levels of pain. While we also, again, want to ensure that analgesic medications are used appropriately. So in addition to preventing any unnecessary suffering and providing ethical and holistic care for our patients, there are several additional reasons we want to treat pain, specifically the short and long-term consequences that result from the both psychological and physiologic stress that untreated pain can cause. So, for example, as many of you might have seen, really severe procedural pain can cause significant adverse events for patients. So increased or decreased heart rate, increased or decreased blood pressure, desaturation, and ventilator dysynchrony. Additionally, studies have found that uncontrolled pain can cause immunosuppression, impaired wound healing, things that we obviously want to avoid in our critically ill patients. And in addition, patients can experience long-lasting psychological effects from untreated pain. So things like anxiety, depression, post-traumatic stress disorder, as well as something called chronic intensive care related pain. So what is chronic intensive care related pain, or also known as CIRP? Well, there's currently no widely accepted definition. One study did define it basically as clinically relevant pain 6 months after ICU discharge that lasts for at least 3 to 6 months, and when the patient specifically attributes that pain to their ICU stay. Studies examining CIRP have found that the incidence varies anywhere from around 33% all the way up to 73% of critical illness survivors. And the risk factors still aren't totally elucidated. A lot of the data is actually extrapolated from the surgical population, but it's found that patients who are at greatest risk are developing CIRP are patients who have pre-existing pain, as well as younger patients, again, female sex. And while those risk factors are obviously non-modifiable, modifiable risk factors include things like high pain intensity and prolonged pain duration. And these are things, again, we can specifically manage with good pain management protocols. And we really want to because, all the studies that have looked at CIRP have found that it really does significantly negatively impact physical, psychological, and social well-being of patients for, again, long after their ICU stay. Okay, so the first polling question. So TR is a 28-year-old woman who was admitted to the ICU yesterday. Sorry, let me close this. After a gunshot wound to the abdomen requiring an exploratory laparotomy. She is intubated and lightly sedated, propofol 20 mics per kilo per minute, but not receiving any analgesia. Upon evaluation and discussion with the nurse, it is determined that the patient is experiencing pain based on her behavioral pain scale score of 7. Which of the following statements is true regarding untreated pain in critically ill patients? So I don't know if, Colin, we can try the poll everywhere question or if we'll just use the chat box.
I think we're going to use the chat function for answering questions. If you could just put them into the chat.
Okay, great. So it seems like everyone pretty much is getting the correct answer. So yeah, so A, exactly. So like we just said, studies have found that untreated pain in the ICU can cause immunosuppression and impaired wound healing, things we definitely want to avoid. B is not correct because we just said that untreated pain does increase the risk of developing CIRP. C is not correct because, so using less opioids and improved patient outcomes. We don't want to use opioids, unnecessarily, but we do know that adequately treating pain actually improves patient outcomes, which we'll, discuss in a little bit. And D, again, same thing. It does, adequate pain management does impact patient outcomes. Even, again, pain first before sedation, but we'll get to all that. Okay, great. Okay, so like we just said, pain, is really such an important part of patient care that it's actually the first component of what's known as the ABCDEF, kind of long-winded, bundle, which is a Society of Critical Care Medicine recommended evidence-based guide, basically for ICU clinicians to really just try and optimize ICU patient recovery and outcomes. And specifically, the bundle recommends that pain be regularly assessed, treated, and prevented. Managing pain is truly fundamental to the rest of the bundle, as improper pain management can lead to agitation and additional sedative use, or even result in delirium. And additionally, patients who have adequate pain control are more likely to, participate in early mobility and exercise, and even more likely to, be engaged with their families, which we also know is very important to improving outcomes. So today, what I'm really going to be doing is going into more detail about the three components of pain management in the ICU. So assessment, treatment, and prevention. So pain, the first part, again, of our management protocol is assessment. We really want to make sure that pain is being routinely assessed, again, reassessed and documented for all ICU patients, as this is absolutely necessary to facilitate treatment and communication among healthcare providers to really come up with a good pain care plan. Ideally, your institution or your unit should have a protocol that states how frequently pain should be monitored and documented. Overall, at a minimum, should be monitored every 2 to 3 hours when patients are at rest. And then pain should be assessed before and after any potentially painful procedure, as well as before and after an analgesic is given, just to make sure that the analgesic is actually working. And obviously our nurses are really going to be the ones who are doing the majority of pain assessments. Other providers, including us as pharmacists, who have honestly a very large say a lot of times in a patient's analgesic regimen, really need to also be aware of how to adequately assess for pain in these patients. So we'll go into that a little bit now. So what are the steps for pain assessment? This American Society for Pain Management Nursing has a pretty nice 5-step approach. So the first step is that we are aware of potential sources of pain. And really the reason that we want to think about that first is that we want to anticipate, what patients are most likely to be in pain and when are they most likely to experience pain. Second, whenever possible, we really want to try to use a validated self-assessment tool. However, patients must be able to communicate, in order to be able to self-report their pain. So for many of our patients who are not able to communicate, we have to move on to step 3, which is to use a validated behavior pain tool. Finally, the fourth step, which we can consider primarily used in conjunction with a behavioral pain tool, is to use proxy reporters, usually family members or very close friends, to help identify pain. And lastly, some patients unfortunately might not be able to be assessed really using any of the above. So in that scenario, we're going to probably try, either an analgesic trial or just assume pain is present and treat. Okay, so let's go to step 1. What are the potential sources of pain? So things like obviously surgery, trauma, any obvious wounds, definitely a history of chronic pain, as well as anything iatrogenic or procedural. So things like wound care, positioning, turning, chest tubes, A-lines, central lines, suctioning, all can cause pain. So the next step is to just try and obtain a patient's self-report. So whenever possible, we really want patients to self-report because by definition, pain is a subjective experience. So the 2018 SCCM Pain, Agitation, Delirium, Immobility, and Sleep Guidelines, commonly known as the PADIS guidelines, which I'll refer to throughout, they recommend using a 0 to 10 numeric rating scale, which is basically, what I think most of us have heard, asking a patient on a scale of 0, indicating no pain, to 10 being worse pain, how severe is their pain? If patients can communicate verbally, you can simply ask them what their pain scale is. However, if patients are awake and alert, but unable, to really talk due to mechanical ventilation or other reasons, you can ask the patient if they are in pain, and if they are, actually use a basically printed out visual depiction of the scale and ask them to point to their level of pain. For some reason, if you have a communicative patient who can't use a numeric pain scale, the guidelines do also recommend a verbal descriptor scale, which is very similar. It's basically just instead of numbers, asking patients to pick the appropriate adjective for their pain severity. So, is your pain mild, moderate, severe, extreme? So an example just here of the verbal descriptor scale that I just mentioned is on top of this slide, while a visual version of a numeric pain scale, what a patient could potentially point to their level of pain, is down here on the bottom. So that is really when pain is much easier to assess in our patients. But where it gets tricky is when patients can't communicate, which unfortunately is a lot of our patients in the ICU. These are patients who are also, very high risk of having pain because of their critical illness and receiving inadequate treatment. In the absence of communication, what we're going to do is a behavioral pain tool. And, those will go into them, but behavioral pain scale and CPOT are the critical care pain observation tool are the ones that are guideline recommended. So vital sign changes, I just want to highlight, things like heart rate, blood pressure, respiratory rate changes. They can be useful maybe if the patient is experiencing severe adverse effects from severe pain, like we talked about with procedural pain. In no way are vital signs able to discriminate pain from any other sources of distress. Changes in vital signs don't necessarily indicate pain, and a patient in severe pain could have completely normal vital signs. So really, they should only ever be used as cues to initiate further pain assessment and not as actual assessment itself. So as I mentioned, one of the original scales that is used to assess pain in non-communicative, intubated, and non-intubated patients is the behavioral pain scale. So this basically just evaluates 3 behavioral categories: facial expression, movement of upper limbs, as well as tolerance of mechanical ventilation, or if the patient's not intubated, vocalization. For each of those categories, you assign a score of 1 to 4, basically add those scores up, and any total score of 5 or higher is basically indicative of unacceptable pain that requires treatment. Okay, and here you can see this is a really great training poster that we've actually used in our unit for the use basically to train anyone in the use of the behavioral pain scale. You can see, they have both on the left looking at what you might look for in intubated patients versus on the right in non-intubated patients. The CPOT, or Critical Care Pain Observation Tool, is very similar, very well validated, also guideline recommended. This one is, again, similar, but instead of 3 behavioral categories, it assesses 4 behavioral categories. And those include facial expression, body movements, muscle tension, as well as, again, either ventilator compliance for mechanically ventilated patients or vocalization. However, with this tool, the various categories are only assigned scores between 0 to 2. So basically with the CPOT, any score of greater than or equal to 3 is indicative of unacceptable pain that requires treatment. Okay, and I'm not going to go through this in detail just for the sake of time, but I had the CPOT on the last slide. It was pretty small though, so here I broke it up onto 2 slides. Again, you can see these are the first 2 categories as well as the score and the description. And it's continued on the next slide. And again, you add up the score for each of those 4 categories. Your final score is a CPOT. Anything 3 or higher requires treatment for pain. So again, behavioral pain tools are guideline recommended for non-communicative patients. Really the best we have in a lot of scenarios, but they do still have several limitations. One is that you really can't think about them in the same way that we think about a 10-point numeric rating scale. So, and you really can't convert it either to a numeric rating scale. So say, for example, you have a patient, you use behavioral pain scale score and they get 10. That's just because it's 10 out of 12 does not mean it's equal to a numeric rating scale of 8.33. And really, we can't even say that higher scores on the behavioral pain scale or CPOT even necessarily indicate a higher level of pain, although that makes logical sense. They just haven't been validated in that way. So it's basically the patient either has unacceptable pain or not. And finally, there's several situations where the behavioral pain tools, really can't be used reliably just because some of the behaviors are not observable. So this includes patients who are deeply sedated, basically what we commonly use is Richmond agitation sedation scale score of less than or equal to -4. So basically anyone who is not awakening to any sort of verbal command. Definitely patients who are receiving neuromuscular blockers, we cannot use behavioral pain tool in, as well as patients with severe weakness or joint malformation. Another something that else can be considered along with the behavioral pain behavior pain tools are proxy reporters. So this is really going to be useful when patients again are unable to self-report their pain. So both PADIS guidelines and the American Society for Pain Management Nursing suggest that family or very close friends can be involved with their loved one's pain assessment. Doesn't correlate all that well, but it seems to be better than nurse or physician approximations of patient's pain. I would say also where I think that family can be really useful, especially as, the pharmacist, is not only identifying acute pain, but really letting you know about any chronic pain that they have or any chronic pain medications they take at home, as this can really contribute and complicate their acute pain management if those are issues we don't know about. Okay, so what happens though with the patients who cannot communicate their pain and the behaviors are not observable? Some of those patient categories we just mentioned. Unfortunately, there are really no adequate alternatives at this time. And essentially, the recommendation is to just err on the side of caution and treat pain if you think there is, any chance that pain is present. So if we think about, again, patients who are receiving neuromuscular blockers, the strategy we take with them, we don't just deeply sedate with a sedative. We assume that they're going to have sources of pain as well, and provide treatment with an opioid analgesic. There also may be select scenarios, where you are concerned a patient might be having pain. Maybe they, you can use some of the behavioral pain tool to assess, but you can't use the full tool. Say again, muscle weakness, you can't assess for muscle tension, etc. You can. It's not ideal, but you can use basically a trial of an analgesic with very close assessment and follow-up, almost as a form of assessment. If you see an improvement in anything that you think could be pain, and they're also having likely sources of pain, that alone can be used as a trial, basically, or as an assessment when we have limited other options. So why do we do all this? Why is pain assessment so important? So one, we know that these patients are complicated and complex, very difficult to distinguish pain from anxiety or delirium if we're not using appropriate assessment tools. And if we're not appropriately identifying pain, then patients might be receiving sedatives or other hypnotics to, again, treat agitation when really we need to be treating pain. And this has been shown time and time again in studies that have really found that, patients who have standardized assessment-driven pain management protocols have better outcomes, including things like reduced sedative use, improved pain scores, increased use of non-opioid analgesics, and obviously most impressively, reduced duration of mechanical ventilation and even length of stay. And despite that we have many studies that support the benefits of routine pain assessment management protocols, pain assessment is not routinely performed in all of our ICU patients. And, I think this is an area throughout the country, throughout the state, that we really need to work on ensuring that every patient in the ICU is regularly assessed for pain so that they can receive adequate treatment. Okay, so just again, as a reminder, this 5-stepwise approach to pain assessment: be aware of sources of pain, attempt to obtain self-report, use a validated behavior pain tool, proxy reporters, and finally, last but not least, try an analgesic trial or just assume pain is present and treat. Okay, so we're going to go into another polling question, although I guess we'll just do the chat again. So this is patient RS. So this is a 67-year-old woman who has a history of poorly controlled type 2 diabetes, hypertension, basically admitted to the MICU with pyelonephritis and septic shock, slightly elevated white counts, lactate of 3.1. Her serum creatinine notably is elevated from baseline up to 1.4, febrile, slightly hypotensive, on norepinephrine, though, as you'll see on the next slide, tachycardic, and a respiratory rate of 23. And her home meds really are only significant for lisinopril, glargine, as well as gabapentin. Okay, so the question basically is, she comes in, she's mechanically ventilated, she's receiving LR at 75 mLs an hour, norepinephrine at 5 micrograms per minute, and a fentanyl infusion at 12.5 micrograms per hour. She's currently agitated and reaching for her endotracheal tube. So what is the most appropriate next step for RS's care? So what would you recommend? Okay, great. So I think everyone's pretty much putting A, which is exactly correct. So we really, again, it's very likely she's in pain, very likely that we'll need to add something on for analgesia, but we always want to make sure that we are actually assessing for pain before we start treating it. And that's really why, again, D is not correct, because we would want to assess for pain before treating it. B, so we, again, patient definitely should be screened for delirium, but we always want to address and treat or assess and treat for pain before worrying about delirium. C is not correct because, again, we only add a sedative agent once pain has been adequately addressed, which we don't even know for sure if the patient is in pain yet. And again, E would not be correct. We need to perform the pain assessment first, and the patient also probably would not be a good candidate for an NSAID at this point, given her AKI, but we'll discuss that further. Okay, so next question. So RS's nurse attempts to ask the patient about her level of pain using a visual 0 to 10 numeric rating scale. However, RS is unable to communicate. Which of the following is a guideline recommended validated pain assessment tool for critically ill patients unable to communicate? Okay, great. Yeah, so as we clearly went over, the CPOT and BPS paper pain scale have demonstrated the greatest validity and reliability for assessing pain in patients unable to communicate. Unfortunately, there are no objective tests to detect pain. There's definitely absolutely no utility in checking a serum cortisol level. And actually, vital sign variability and pupillary reflex dilation have been studied for the detection of pain in critically ill patients, and there has been some positive results. There's really just not enough data to recommend any of these novel technologies at this time. So C, great. Okay, so once we identify pain in a patient, what's the next step? We need to treat it. So the 2018 PADIS guidelines recommend that basically all analgesia assessment and treatment be protocol driven, but we also do want to keep in mind that regimen should be individualized as needed to best treat our patients. So opioids remain our first line for analgesia, but actually might not always be needed. There recently has been a greater focus on non-opioid analgesics and non-pharmacologic interventions, either alone or what's more common is being used in conjunction with opioid therapy. And one of the fundamental tenets of our bundled care, that A, B, C, D, E, F bundle for ICU patients, is that we always want to make sure that we're treating pain before adding a sedative agent. Again, several studies have demonstrated that patients who have their pain treated before a sedative agent is added have improved outcomes, including, again, reduced time on the ventilator, reduced length of stay. And apologize, next slide. Okay, so as we mentioned, we do want our pain management protocols to be, or we want our pain management in the ICU to be protocol or guideline based, but we do have several considerations to keep in mind when recommending a multimodal and patient-specific analgesia regimen. So first, there are several patient factors we need to consider. So to start off, how severe is the pain? Is it so severe that they definitely are going to need opioids? Or is it milder pain where we can get away with a non-opioid agent alone? What's causing the pain? Is the pain nociceptive or neuropathic? Additionally, we know every medication has adverse effects of some sort. And is your patient potentially at an increased risk of a specific medication adverse effect, or would that potential adverse effect be detrimental in your patient? Obviously, need to consider any allergies. Things like allergies to NSAIDs would preclude use. Does the patient have chronic pain, or are they on any medications for pain at home? We definitely, as we said, we want to restart those or the equivalent of those if at all possible. What sort of access does the patient have to receive medications? Can they take medications by mouth? Do they have enteral access? Is there any concern for impaired GI absorption that would limit the use of enterally administered medications? And a big consideration when choosing analgesics and the appropriate doses in our patients is any organ dysfunction. So if a patient has or is at very high risk of developing renal impairment, definitely recommend against using morphine, which has an active metabolite that accumulates in renal failure, and definitely recommend altogether against using NSAIDs, which can obviously cause or worsen AKI. And if the patient has severe hepatic impairment, would probably either dose reduce or avoid acetaminophen altogether. It's also important to keep in mind, I think sometimes we forget, especially in the ICU, but for especially our patients who are still able to communicate patient wishes. So if you have a patient who has a history of opioid use disorder and wants to avoid opioids, really we should be assisting the team in any way possible that, to try and do that, to try to use every, safe non-opioid analgesic possible before, having to take the step of reaching for an opioid. Certain medication factors, obviously pharmacokinetics, pharmacodynamics, especially when it maybe comes to choosing one opioid over another. Can't forget that, drug interactions, as well as dosage form availability and just availability based on your institutional protocols and guidelines, your formulary, things like IV acetaminophen. Obviously, I know at Bellevue, we definitely do not have access to it. I think a lot of hospitals are very restricted with access, but that can play a role as well. So as we already mentioned, opioid analgesics remain the first-line option for the treatment of pain in most critically ill patients. And actually around 85% of mechanically ventilated patients receive opioids during their ICU stay. So in intubated patients, they can be beneficial because they also have the additional benefit of improving synchrony with the ventilator as well as reducing agitation. And while we have several opioids to choose from, they're really all equally effective at equivalent doses, and choosing one over the other should usually be patient-specific. Other considerations with using opioids is whether they should be, specifically IV opioids, is whether they should be given as intermittent boluses or a continuous infusion. There's really not a lot of data actually on this in adult ICU patients, but it has been found in pediatric patients that intermittent dosing may be associated with less opioid administration and shorter duration of mechanical ventilation. Also, tolerance to opioids can develop with any mode of administration, but patients are less likely to develop tolerance with intermittent dosing as compared to continuous infusions. However, we do have to balance that, the benefits of intermittent dosing with the risk of increased agitation and self-extubation when using intermittent doses. And I think this is especially important right now in the setting of nursing shortages. I know we've had a lot of traveling nurses, a lot of nursing turnover in our unit, and there's been a lot of pushback to using an intermittent dosing strategy. But whenever possible, I generally do recommend that, we try intermittent first, just because, again, of the better outcomes seen, at least in pediatric patients. And once patients are requiring around 2 doses an hour, then consider starting a low dose continuous infusion. Enteral opioids also can be used in patients with adequate access, absorption, and motility, but they're not titratable. So this is really going to be more for your patients who are a little bit more stable. Maybe you have an idea of what they're going to require for their opioid regimen. And then patient-controlled analgesia, really going to be mostly in the surgical population, but if your patients do have the cognitive capacity and physical ability to use it, it's a great option, again, especially for post-op patients. And regardless of the mode of administration, whenever we're using opioids, of course, we want to use the lowest effective dose just to try to minimize any unnecessary adverse effects. Okay, so let's take a look quickly at our opioid options. So fentanyl, definitely the most commonly used IV opioid in the ICU setting. It has a very fast onset of action of 1 to 2 minutes, but I do want to point out that this fast onset of action really is only applicable to when you're giving a bolus dose. So if you just start a patient on a continuous infusion or just, say, increase the rate of an infusion, but don't provide a bolus, it'll take a lot longer to achieve that new steady state, almost 30 minutes to see the effect of that increased dose. And this is why when we do have a patient in acute pain, we always recommend bolus dosing, almost always, I should say, when starting an infusion or increasing the infusion rate. So fentanyl also is hepatically metabolized and will definitely accumulate in hepatic failure. But the good thing is it does not have any active metabolites and is generally considered safer than, say, hydromorphone or morphine in patients with renal impairment. Additionally, fentanyl is extremely lipophilic, and so it really tends to accumulate in the peripheral compartments. And that's really why it has a context-sensitive half-life. If you were to give 1 bolus dose, the half-life of fentanyl is about 30 to 60 minutes. However, when you give multiple bolus doses or a continuous infusion, the half-life is significantly prolonged. Hydromorphone is probably our second most commonly used opioid, at least in my ICU, in my hospital. It has a slightly longer duration of action, slightly longer onset of action than fentanyl. And when used as, say, a one-time dose, tends to have a slightly longer, intermittent dosing has a longer elimination half-life. As compared to morphine, it is safer to use in renal failure, causes less histamine release. Really, I would say we use this mostly for intermittent dosing or as a continuous infusion if we think that patients have developed acute tolerance to fentanyl. It tends to be our go-to for opioid rotation. And then morphine, one of our oldest IV opioids, again, does work, but I generally don't recommend this for use in the ICU just because it does accumulate in hepatic impairment, also has active metabolites that accumulate in renal impairment, can really lead to prolonged, unpredictable effects in patients with renal impairment. And as compared to our other opioids, it can cause hypotension and bronchospasm from the histamine release. I'm not going to go too much into detail here, but just so you know, there are other opioid options. Methadone is one that tends to, I feel like, gets hot for a little while, and then people tend to stop using it as much. There is some data that it can be useful in transitioning patients off of continuous IV opioid infusions. Say patients who have had a prolonged ICU length of stay, have been requiring high amounts of IV opioids. Again, could be useful as a transition to try and expedite weaning off and getting the patients off the vent. The big thing, though, is that it's got a very variable half-life. And so especially in patients who are no longer intubated, you need to be very careful with initiation and dose titration, as you can get pretty significant respiratory depression several days later after any dose increases. And obviously it does prolong the risk of QTC, does prolong the QTC as well. Oxycodone is probably our go-to, most common go-to oral agent. So if you want to switch a patient over to orals, the immediate release formulation can be crushed, also available as a liquid. Does have to be dose adjusted, or should at least be cognizant that it can accumulate in renal and hepatic impairment. Tramadol I included. I'm not sure how everyone else, if anyone else works in a surgical ICU or has seen this, but it's sometimes considered a non-opioid medication, although not really, just based on a lot of the mechanism and the side effects. And I have some attendings that really think of it as almost a safer alternative. But again, has the same adverse effects as our standard opioid agonist, plus some additional adverse effects like seizure risk, serotonin syndrome. Additionally, it's metabolized into an active metabolite, and because of that, patients can exhibit very different responses to it. So overall, I really don't recommend it. And that sort of, falls under use with codeine, the same thing, can be used, yes, but probably shouldn't be just given the variable patient response. Meperidine, anything other than shivering just should not be used because of the risk of neurotoxicity with the metabolite that can accumulate in renal failure. And lastly is any dosage formulations with acetaminophen. So that's really going to be anything any only oral agents. Not that we should not be using acetaminophen as a multimodal agent, but I find it's generally safer when we separate the acetaminophen from the opioid. That way there's no risk of accidental duplication orders with acetaminophen. So opioids obviously still are mainstay of therapy for pain in the ICU. There are many adverse effects that we need to keep in mind. So patients often experience bowel dysfunction like constipation or even ileus. They can experience excess drowsiness and respiratory depression, which really a lot of times becomes a problem after, say we want to extubate the patient, we discontinue the medication, the respiratory and CNS depressant effects are still on board. And again, this can really be a problem when we have patients on prolonged infusions of fentanyl, especially with hepatic or multi-organ dysfunction. Opioids can cause hypotension, although a lot of the hypotension that's seen is probably just from blunting the sympathetic response to pain. Similarly, while pain can cause immunosuppression, actually so can opioids, and this is similar with delirium. Delirium has been associated with uncontrolled pain. Interestingly enough, also associated with opioids as well. In terms of other adverse effects, so patients can develop tolerance to opioids pretty quickly, and as a result see with opioid withdrawal when we stop the opioids. We can also see acute tolerance where patients can develop tolerance for an opioid as soon as 48 hours after initiation, basically requiring very quickly escalating doses. This can usually be treated with an opioid rotation, so say switching the patient from fentanyl to something like a hydromorphone infusion. Opioids can also cause hyperalgesia, which is essentially increased sensitivity to pain due to opioid exposure. And this is, we really tend to see this in patients who have been on chronic opioids and are exposed to high doses of opioids in the ICU. And finally, in the light of the ongoing opioid epidemic in this country, I don't think we can ignore, the possibility that opioid exposure in the ICU could be a risk factor for ongoing opioid dependence or even opioid use disorder after the patient is discharged from the unit. And until recently, this has been a concern for a little while, just given everything, but there really has not been any data that addresses this question until this retrospective cohort study really sought to identify the incidence of ongoing opioid use, as well as risk factors for ongoing opioid use after patients were discharged from an ICU stay. And so again, this was a very large retrospective cohort study. It basically evaluated over 200,000 patients who were admitted to Swedish ICUs between 2010 and 2018. And wanted to look at, again, ongoing opioid dependence, which they really defined as persistent use of opioids as prescriptions for opioid-containing medications more than 3 months after the patients were discharged from the hospital. And they actually found that 11% of patients discharged from the ICU, so 11% of those over 200,000 patients actually developed subsequent chronic opioid use. So a rate that was, pretty staggering to me. And they found that the patients who were more likely to have subsequent chronic opioid use after their ICU stay were older, more likely to be female sex, lower education and income level, more comorbidities. not surprisingly, had a greater rate of pre-admission opioid use, more likely to be surgical patients, earlier year of ICU admission, so basically earlier on in that 8-year time span, patients who are in the ICU for longer, as well as actually your less critically ill patients. And so, this is only one study that was, again, very large study, but only conducted in one country. So I think we do need more data on this, but I think, the results of this study should at least lead us to, question some of the potential long-term impacts we're having, with our high opioid use in the ICU, and hopefully we'll see more data on this moving forward. So this leads us to the question, what's the sweet spot where we're minimizing pain and suffering for our patients while also reducing the negative outcomes associated with untreated pain in the ICU, and at the same time trying to limit adverse effects from opioids and minimizing the risk that our patients develop, inappropriate long-term opioid use after their ICU stay. So how can we possibly achieve this balancing act? There's no perfect answer, but one way is to utilize multimodal analgesia whenever possible. So multimodal analgesia basically is combining the use of multiple analgesic classes, each having different mechanisms of action. And the goal is to really optimize analgesia while reducing opioid use, reducing analgesic side effects. The PADIS guidelines do recommend using a patient and symptom specific multimodal analgesia regimen whenever possible, even though they do say, and it's very true, that there is very limited data from the ICU population specifically, and a lot of the data for our multimodal therapies or non-opioid analgesics are extrapolated from the surgical population. So on the right side of this slide, you can see this is basically was published with the PADIS guidelines as a supplemental appendix. It's just essentially an algorithm for the use of adjuvant analgesics. And really it starts by asking, is the patient at risk for opioid adverse effects, which really you could argue, I think, that almost any patient receiving opioids in the ICU is. Some are obviously more concerned than others. But then the next question is, okay, well, what type of pain is your patient experiencing? If it's neuropathic pain, definitely a neuropathic agent. I would say most commonly gabapentin, maybe pregabalin. I don't think carbamazepine is really ever indicated over those two, except for obviously seizure disorder. And then what we see more commonly though in the ICU is going to be nociceptive pain. So you can see several agents can be used, things like acetaminophen, low-dose ketamine, and even in select patients, primarily post-operative patients, those neuropathic agents again. There are other non-opioid adjuncts like IV lidocaine and basically using more than one dose of NSAIDs that the guidelines actually do not recommend for, just given safety concerns as well as limited efficacy data at this time. And, despite us having several options for, adjuvant analgesics, again, sometimes it's not possible to use any, but actually studies have found that less than 1/3 of mechanically ventilated patients receive a non-opioid analgesic. So something we can probably, again, not every patient can receive non-opioid therapy, but I think we could probably do a better job overall using multimodal therapy in our critically ill patients. So again, very limited data to support use of any of our adjuvant non-opioid analgesics. And, unfortunately, we don't have time to get into all the small studies. There was recently a pretty great systematic review and meta-analysis by Wheeler and colleagues that was basically published evaluating the efficacy of non-opioid analgesics in critically ill patients. And so you can see there's a forest plot on the right, and it's describing the impact of non-opioid analgesics 24 hours after the intervention. And if we zoom in a little bit, you can see that taken together, again, overall low quality evidence, but it does suggest that adjuvant non-opioid analgesia improves pain scores for our ICU patients, at least, up until 24 hours after the intervention. Very similarly, it also looked at if there was any impact of non-opioid analgesics on opioid consumption 24 hours after. They similarly found that, again, non-opioid analgesics did reduce opioid requirements. Okay, so let's just take a quick look at some of these adjuvant analgesics in more detail and some of the considerations for use. Acetaminophen can be used in almost all patients unless they have extremely severe hepatic impairment or they can't receive any of our dosage formulations for various reasons. The majority of our data for acetaminophen in ICU patients is IV formulation. Unfortunately, it's often cost prohibitive. And the IV formulation can actually cause pretty significant hypotension around 30 minutes after the infusion. Alpha-2 agonists, so they actually were not even mentioned in the PADIS flowchart or guidelines in terms of, specifically for analgesia, but we do have post-op data that demonstrates efficacy and, opioid-sparing properties. Additionally, they can be really useful if you have a patient who has hyperalgesia or they're also experiencing any opioid withdrawal symptoms. But obviously, they can cause bradycardia and hypotension, and actually themselves can cause withdrawal symptoms with prolonged use and sometimes require a taper once you want to come off of those agents as well. Finally, NSAIDs. So again, the guidelines did recommend against routine use in our ICU patients, but they can be used in select populations. In our trauma unit, we see, maybe some young patients that are probably healthier than a lot of other critically ill patients. And as long as they're not at any sort of risk for AKI, they're hemodynamically stable, receiving tube feeds, low at risk of any GI ulceration, we often will use ketorolac, but I think it's, scheduled ketorolac for 3 to 5 days, but I think it has to be a very essentially healthy, critically ill patient to really consider using more than one dose of NSAIDs in. Again, ketamine. So the guidelines do suggest using it at low dose to treat pain and reduce opioid requirements, specifically in the post-op population, just because that's where the majority of the data is. It can be really useful in patients with opioid tolerance or if they have difficult to control pain, hyperalgesia. But we do want to avoid any higher doses, so things like over 1 milligram per kilo per hour, as this can really cause some pretty serious psychological and emergence reactions. Next is our gabapentinoids. So if we remember from the PADIS flowchart, neuropathic meds are obviously recommended for neuropathic pain, but the guidelines also do suggest using them in combination with opioids for ICU patients after cardiac surgery. There has been a lot of concern, though, lately about basically, when used in conjunction with opioids, increasing the rates of opioid overdoses and adverse effects. So I think this is something to definitely be aware of, and I wouldn't always think of it as a safe alternative if you have a patient who is at risk of, say, respiratory depression from opioids at baseline. And finally, IV lidocaine is not recommended for routine use. I would say, maybe in select post-operative patients who are at extremely low risk for toxicities. The thing is, the toxicities that when you do see lidocaine toxicity can be extremely serious and often life-threatening. So I really wouldn't recommend this be routinely used unless, in extreme cases, have pain management involved, or definitely have, your hospital unit has a specific protocol for use to ensure, again, safe use with, close detection of any possible toxicities and treatment of toxicities. Another option for multimodal analgesia is regional analgesia, especially in our trauma or surgical patients. So things like peripheral blocks or most commonly epidurals. So really useful for lower abdominal, lower extremity, thoracic surgeries. Actually, 2013 guidelines actually did recommend that thoracic epidurals be used for post-op abdominal aortic aneurysms and suggested considering thoracic epidurals for patients with traumatic rib fractures. Thing is, there are a lot of contraindications, especially to say epidurals, things like coagulopathy, patients who are hypotensive. So again, really going to be a select trauma or surgical population that these are useful in. Camp-rate or non-pharm therapy, I think some of this is going to be resource dependent depending on what hospital you're at, but things like obviously psychological support is key. I think more and more institutions are realizing a lot of pain. Pain in general needs psychological support, but definitely people in the ICU. So that's a key component. Things like massage, physiotherapy, relaxation techniques, cold therapy can all be used as really ways to try and improve pain control with very minimal adverse effects. Okay, so polling question number 4 is basically, if we think back to patient RS, the patient who had septic shock was starting to pull at her ET tube on fentanyl at 12.5 micrograms per hour. We determined that she needed to have a behavioral pain scale score done. And the nurse basically comes back and tells you that her BPS score is 7. So what do you recommend for RS at this time? Okay, great. So I think everyone I'm seeing right now is answering D, so that's perfect, exactly. So her BPS score is 5 or higher, it's 7. So we definitely want to make modification to her pain regimen. This time D is going to be the most appropriate. We want to bolus, get that onset of action quickly, increase the infusion. Acetaminophen really wouldn't be appropriate at this time, just given that she is hypotensive. We know IV acetaminophen can cause hypotension. We should at this time focus on the fentanyl bolus and increasing the infusion. Okay, another polling question about RS. So the next day, she's really improving. She's on norepinephrine still, but it's down to 2 micrograms per minute, and her serum creatinine is now decreased down to 0.8. Again, it was 1.4 yesterday, 0.5 at baseline. All of her other labs have returned within normal limits. The team has placed an NG tube overnight, and she's tolerating tube feeds at 10 mLs an hour. At this time, she's now up to 50 micrograms per hour on fentanyl, which is being titrated to a BPS score of less than 5. She's no longer agitated, but her latest BPS score is 6. What do you recommend for analgesia at this time? Okay, so I think most people are putting B. So I think, so I definitely agree in adding the gabapentin back on. As we mentioned, gabapentin can, when it's suddenly stopped, can cause withdrawal symptoms. So we definitely, as soon as we have enteral access, if there's no contraindication, we definitely want to start that. However, a big tenet of multimodal therapy is using, again, as sort of, I don't want to say as many agents as possible, but taking advantage of different mechanisms of action. So again, yesterday, the IV acetaminophen was not appropriate because, she was hypotensive. IV acetaminophen can cause hypotension, but at this time she's got enteral access. We have no signs of hepatic dysfunction. Gabapentin's a whole med, so that's sort of just adding back what she was on to prevent any withdrawal symptoms or increase pain from stopping that. But it would be great if we could, add on acetaminophen, and also potentially that'll allow us to titrate her fentanyl down, to a lower dose by using other non-opioid methods. So really, at this time, unless there's was a contraindication to acetaminophen, we want to be adding on multiple agents that are all safe, but ideally will help control her pain while reducing the opioid requirements. Okay, and very, very quickly, I'll just touch upon prevention as part of our pain management protocol. So again, many procedures and aspects of routine care in the ICU cause significant pain for patients. The procedures that have been identified as most painful are chest tube insertion removal, A-line insertion, as well as wound drain removal and insertion. And usually procedural pain is definitely more severe than pain experienced at rest, and often twice the intensity of non-procedural pain. So what should we do? So ideally, patients should have their pain assessed before and after procedures and have pain treated preemptively before the most painful procedures. The most important aspect to really treating pre-procedural pain is just timing the medication so that it coincides with the procedure. And honestly, I find this to always be a struggle and require just a lot of communication between the team performing the procedure and the bedside nurse, really communicating, knowing when the team's going to be there to do the procedure, making sure the nurse knows when to give it. And also, we don't want to forget our non-pharmacologic options. So things like with chest tubes, using a cold pack, again, very low cost, really no side effects, and can help minimize our analgesic requirements. Okay, so in summary, managing pain in the ICU is an essential humanistic aspect of medicine. And while we want to minimize any acute suffering for our patients, we also want to minimize the risk of short and long-term adverse effects, both from uncontrolled pain and from any analgesics we want to use to treat pain. The most important thing to remember, I would say, are the 3 components of pain management. So assess and reassess, treat, and prevent pain. getting ahead of it before it starts. Overall management should be, protocol based and stepwise, as this has been shown time and time again to improve patient outcomes. And again, we always want to make sure we're treating our pain before ever adding a sedative agent, because often, again, agitation is really just due to under-recognized and undertreated pain. And finally, we always want to think of our patients sort of in a holistic view and incorporate key patient considerations to create an individualized and effective analgesia regimen.
Okay, thank you so much, Dr. Moore, for that presentation. For the sake of time, if you have any questions regarding Dr. Moore's presentation, we are going to ask that you direct them to the NYSCHP office, and we will connect you with her offline to get those questions answered. I'm going to move into the CE codes for the first presentation today. So for the presentation today, the CE code for pharmacist is illness, and the CE code for technicians is negative. Again, the CE code for pharmacists is illness, and the CE code for technicians is negative. And again, thank you, Dr. Moore, for that great presentation. Now we're going to move, thank you very much. We will move on to our second speaker for this evening, which is Dr. Kaitlin Landolf. Dr. Kaitlin Landolf is a board-certified critical care pharmacist at the University of Maryland School of Pharmacy and the University of Maryland Medical Center. Her practice sites are in the medical and neurocritical care units. After graduating from pharmacy school at the University at Buffalo School of Pharmacy and Pharmaceutical Sciences, she went on to complete her PGY1 residency at the University of Pittsburgh Medical Center Presbyterian and a PGY2 in critical care pharmacy at the University of Maryland Medical Center. She currently serves as the treasurer for the Baltimore chapter of the Society of Critical Care Medicine. Some of her research interests include optimizing sedation and analgesia in patients with critical illness, as well as medication use and transitions of care in the inpatient setting, starting in the ICU. And Dr. Landolf will be presenting Getting on Board, Opioid Stewardship in the ICU. And again, I will give the CE codes at the end of the presentation, and if you have any questions for Dr. Landolf throughout, just use the chat feature. And I will turn it over to you.
Great, thank you for that introduction. So I'm going to go ahead and get right into it. Thank you guys for joining us this evening. So before I begin, I have no conflicts, no actual potential conflicts of interest related to this presentation. And our objectives are going to be to find opioid stewardship, review the current literature regarding opioid use upon transitions of care from the ICU, and to identify key elements of opioid reductive strategies and their application in the ICU. So to frame this, let's start with a patient case that might sound a little familiar to you guys. Patient AE is a 50-year-old male with a past medical history significant for obesity and recently diagnosed hypertension who was previously admitted to the ICU with COVID-19 ARDS and is now on the acute care floor. After a prolonged ICU stay, AE is discharged to the floor and oxycodone 5 milligrams every 4 hours is needed for pain. 3 days later, you are called to a rapid response for AE who is now unarousable with decreased respiratory rate and pinpoint pupils. So perhaps more could have been done for this patient to prevent his overdose prior to transfer to the floor. As we just learned, good pain assessment strategies and treatment are very helpful to make sure we're appropriately treating patients' pain without over-treating them. So my hope at the end of this presentation is that you're able to understand the importance of opioid stewardship and implementation of opioid reductive strategies to prevent these types of events from happening in and out of the hospital. This kind of leads us to current trends in opioid prescribing, which might also be a familiar graph that you might have seen. And you can see that there have been 3 waves of the opioid epidemic. So currently, we're in the part of the wave to the right where Most opioid overdose deaths are due to synthetic opioids like tramadol or fentanyl that are prescribed or illicitly manufactured. And we've seen a plateau in those patients that are those deaths that are due to heroin and commonly prescribed opioids. Not depicted in this graph, but in 2019, 2/3 of drug overdose deaths were involving an opioid. And CDC data more recently has reported that in the first quarter of 2020, prior to the COVID-19 pandemic, the overdose deaths were on the rise over the past year. And we know now too that before the pandemic, opioid use was increasing and deaths were increasing, and we know that during the pandemic that's only continued to increase. So tying this back into the ICU, opioids are usually started in alignment with the pain and agitation, delirium, immobility, and sleep guidelines, where in addition to a consistent approach to pain management and assessment, there is an analgesia first approach with oftentimes IV opioids continuing to be the mainstay for those patients with non-neuropathic pain. Additionally, as we've just learned as well, as multimodal pharmacotherapy is used to minimize and or spare opioids and sedatives in this setting, and it's kind of the standard of care to incorporate these multimodal agents. So how much opioid are we using in the ICU? A prospective observational multi-center study in 51 ICUs in Canada had found that up to 90% of mechanically ventilated patients received narcotics in the ICU. And the longer that patients were mechanically ventilated, as you can see here, the longer or the higher their average daily morphine milligram equivalents. So in those patients in the ICU mechanically ventilated for over 2 to 7 days, they use 62.9 milligrams versus those patients that remain mechanically ventilated for more than 7 days. And this was found to be statistically significant. And there's also been studies finding that about 63 to 86% of patients receiving sedation also received opioid analgesia. And this makes sense, as we know, we would hope that these numbers would be higher and that patients were receiving an analgesia first approach and then sedation afterwards. So what are the consequences of opioid continuation from the hospital, from the ICU, from the floor to discharge? So there are short-term side effects that we know, you can have oversedation, coma, delirium, impaired rehabilitation and mobilization, as we've discussed earlier, in addition to long-term consequences that can lead to things that we don't intend to happen. So patients developing a tolerance, dependence, or possible withdrawal when stopping opioid consumption. Administration duration may influence this, and there are pharmacological effects as well that we find where similar doses of morphine are about half as effective as analgesics after as few as 24 hours. So these patients may be developing tolerance within 24 hours of their ICU stay. And opiate tolerance, obviously is going to happen most commonly in those patients perhaps that are receiving continuous exposure to a high dose, high potency opioid. And then moving into dependence, opiate dependence is established after oftentimes or as soon as 1 week, which our patients in the ICU may be in the ICU receiving opioids for as long as a week or more. So dependence is possible amongst that patient population. And then withdrawal is also something that can occur, and we don't have a great way to assess for withdrawal in the ICU, as I'll talk about later. So this becomes difficult when you aren't sure if a patient's going through opioid withdrawal or they're having pain, especially when they're not able to communicate what exactly they're feeling. Diversion is also a consideration and a concern when patients are discharged home on these medications and might have extra pills laying around. Others can get a hold of these as well. And I wanted to touch base on opioid-induced ventilatory impairment, which is oftentimes associated with patients receiving excessive sedation and upper airway obstruction. So it's something that you want to be cognizant of in those patients that are on multiple respiratory depressant agents, such as opioids and benzodiazepines. And additionally, those patients that have multiple prescribers for opioids or medications, obstructive sleep apnea, snoring, obesity, or COPD. And then opioids can contribute to falls in the elderly population especially, and mortality, as we saw with, opioid overdoses. So we definitely want to be cognizant of how much opioids we're using, but we do also want to make sure we're ensuring that our patients are receiving adequate treatment for their pain. The Joint Commission has released pain management standards for hospitals, and as part of these standards, their key things that they are assessing or that they recommend that hospitals have that are accredited by the Joint Commission involve having medical staff in leadership roles that really help make it a priority for the organization to have improvement activities to improve quality of care, treatment, services, and patient safety. They also recommend having adequate pain assessment scales and managing with safe opioid prescribing practices, while also increasing patient education and engagement, helping patients kind of be part of their treatment plan. And, like as mentioned before, if you have a patient that's trying to avoid opioids, then helping them find other agents that could potentially manage their acute pain in that setting. They also recommend providing at least one non-pharmacologic pain modality when there is a need for pain treatment, so having at least one modality available to patients, and also increasing referrals to opioid treatment programs, and having quality improvement to reassess the prescribing practices, safety, and all of the above as different rollouts of opioid stewardship programs occur. So kind of getting into the crux of our presentation, I'm going to start with opioid stewardship. We oftentimes hear stewardship affiliated with antimicrobial stewardship, but opioid stewardship is a relatively newer term. So breaking it down, stewardship is really conducting, managing, or supervising a process to oversee an organization or utilization of resources. What that means then for opioid stewardship, kind of the best definition I've found for opioid stewardship is having a coordinated set of interventions or coordinating interventions aimed at improving prescribing, mitigating risks, and monitoring the use of opioids. So how does this pan out, in a hospital system where you have to roll this out? This process here was delineated by Fairview Health Services in Minnesota, and they started this in 2001 with a collaborative pain practice that they developed in 2014. And they kind of highlight their process of getting to an opioid stewardship program throughout their healthcare system. And it all started with naloxone trigger and adverse effect tracking that developed into opioid policy standards, leveraging information technology to help with ordering and appropriate ordering of medications, developing into a pharmacist collaborative practice for stewardship, and then a collaborative inpatient pain service. So in their initial role of the pharmacist at Fairview Health Services in this rollout, they had pharmacy practice policies where they would prohibit dosing ranges greater than 2 times normal, standardized PCA orders. They had opioid tolerance verification before continuous infusion, so assessing if patients were tolerant before they were started on an infusion. They adjusted doses in end organ dysfunction, reviewed long-acting agents, and also reviewed the prescribing management programs, seeing if patients were filling opioids and how frequently, etc. So in the ICU, we do some of these things, including adjusting doses and end organ dysfunction, verifying tolerance before continuous infusion. So there's some things that we, inherently incorporate into our roles when we're in the ICU or when we're verifying orders. So they found, however, with these policies, that there was inconsistent enforcement by different pharmacists, so everybody kind of did it differently. It was confusing as who was going to enforce this. So was it the providers or the pharmacists who were accountable for following up on all of these things? And there were quite a few policies to roll out at once, which was a burden to the workload and which really couldn't support this as well. So they transformed the role of the pharmacist after, their quality assessment and, relooking at the process and seeing if it made sense, and developed the Pharmacist Collaborative Practice Agreement, where pharmacists were involved with collecting medication histories, reconciling those meds, assessing for indications and contraindications for appropriateness of opioids. And then there were order entry protocols, so medications could be entered by the pharmacist, who then would document progress notes for changes or initiations of medications. And this obviously was all in collaboration with consulting teams and prescribers, and ultimately, if there was a discrepancy, the prescriber can override these orders. And then looking at opioid stewardship program in a different hospitals system, Brigham Health delineates their framework for a health system wide initiative to decrease opioid-related morbidity and mortality. And so as part of their opioid stewardship program, they implemented prescribing task force, addiction task force, education initiatives. They had information technology, prescribers, decision support, and also opioid-related metrics. And they found with their implementation of this program, they had decreased the number of prescriptions by about 72.5 per month, which was statistically significant for their patient population. And they were able to decrease the morphine milligram equivalents of about 0.4 milligrams per month, which was also found to be statistically significant. And they also had an increase of buprenorphine prescribing about 6 scripts per month as well. Interestingly, they did not find that the visits to the hospital for opioid overdose, they didn't find that had changed. And so ideally, with these programs, we have this rollout, and it helps eventually with the community as well in terms of decreasing overdose events and patients coming in with side effects from opioids. What they had found is that successful implementation required strong sponsorship, ensuring that it's not just one department responsible for stewardship, but it's multidisciplinary, and there's empowerment for it to be multidisciplinary, and having inclusive measures to guide efforts. One last aspect of developing an opioid stewardship program that I wanted to talk about, this is a publication or an implementation guide by the American Hospital Association. And this is kind of their recommendation for elements of an opioid stewardship program that you want to have for measurement strategies to kind of follow up on these practices and see if they are impacting your organization in a positive way or your hospital. So they start with leadership strategy and patient engagement. So having that buy-in from leadership and having it be a priority that opioid stewardship be performed, or that you have a program for this, and having patient engagement in the process as well in their own treatment of their pain. They also include an environmental scan, so assessing what services are already in effect and the capacity to create new and improve old services that you've got. Deciding, what as part 3, deciding as what evidence-based guidelines and things that you want to focus on, and interventions and outcomes that you want to look at. 4, having goals set for the program and ways to improve, having that constant circle of quality assessment of the program. Having policies and care team education, so educating the providers, nursing staff, and everybody involved in the process, and then again educating the patients and engaging them in the endeavor. So from these previous studies and papers that I talked about, components of a successful opioid stewardship program seem to include leaders prioritizing opioid stewardship, they're multidisciplinary, they follow pain management guidelines, they have protocols that are multidisciplinary, and they're approved, and there's buy-in by everybody that's part of that interdisciplinary team. Staff education, education in general for patients, and then having analysis and reporting of data, and that community collaboration, making Narcan accessible to everybody outpatient, or as they go outpatient if you need to, having outpatient pharmacies that are able to do this as well. So what's the current state, or how are opioid stewardship programs doing? So in 2019, ASHP had surveyed, they published the results of their 2018 survey of pharmacy practice in hospital settings, and they had surveyed 4,897 directors, so about 5,000 pharmacy directors, with about 16% responding. And what they really found is that about 41% of hospitals that responded had active opioid stewardship programs that had different components. So there wasn't consistency across the board with what components these programs included. But they did find that pharmacists were most oftentimes involved with diversion and detection, clinical utilization review. They were part of the leadership and accountability, and they also helped with prescribing support. And then another cross-sectional survey looking at hospital best practices for opioid use was published, and their objective was to establish hospital practice patterns aimed at improving opioid use. So they had surveyed about 133 hospitals, and they found that in their survey that 23% of hospitals had stewardship programs, only 14% had prospective screening for opioid-related side effects or adverse effects, and only 45% of hospitals had PCA restricted. 90% though had a pain management service, with about 67% of palliative care providing pain management at these hospitals. So going into our audience response question, which of the following are included in the definition of opioid stewardship? Select all that apply. Is it coordinated interventions, improving prescribing, monitoring, or risk mitigation? Yeah, so I'm seeing a few all or multiple choices. So it's all of the above. So we want to make sure we've got those coordinated interventions, that we are working to improve prescribing, monitoring, and risk mitigation. So these are all components that are part of the opioid stewardship definition, making sure that we're working together to improve prescribing, monitoring, and preventing adverse effects of these agents. Next, I'm going to talk about opioid transitions, or opioid use across transitions from the ICU. This is really to see, to get a better understanding of opioid prescribing and kind of what it looks like currently. Unfortunately, due to the nature of the data, this is really limited to retrospective data. We don't have great prospective studies really looking at this, but we'll talk about a few studies that have looked at opioid continuation from the ICU. So Dunn and colleagues had conducted a single center retrospective cross-sectional study in traumatic brain injury patients after recognizing that these patients might be an increased risk of psychiatric and substance use disorders. In their study, they had included about 300 adult patients with traumatic brain injury that were admitted to their neuroscience ICU, and they had excluded patients that were polytrauma or treated in their surgical ICU. And those patients that had also major injuries of their chest, abdomen, pelvis, that were potentially associated with a TBI, they just selected those patients that had a TBI as their main problem. This study included both opioid users and opioid naive patients, and the primary outcome was persistent opioid prescription through 12 months after discharged. So what they defined as persistent was having a prescription for one or more opioids at each of 1, 6, and 12-month time points. What they found is that in their patient population, in their prior to admission opioid users, they found 87% at 1 month, 69% at 6, and 56% at 12 months had prescriptions for opioids, which we would expect to, if they have chronic pain or they're chronic users and they've been using, you would probably expect to have a higher increase of continuation at those time points. And on the flip side, in their opioid naive patient population, they found that at 1 month, 41% 23% at 6 months, and 19% at 12 months had prescriptions for opioids and persistent use. But you can see over time that seemed to taper, and there were less patients at each interval that they checked that were receiving opioid prescriptions outpatient. So what they found what was associated with increased risk of opioid prescriptions at 12 months post-discharge, what they found was associated with this was pre-admission opioid use and higher opioid requirements during the hospitalization. Of course, due to the nature of the retrospective study, it was limited in the fact that there was a lot of missing data for the complete cohort, which could change what their true outcomes were. And this is going to be a limitation of really all of the studies, is that being retrospective, they're missing some key points of data and might have excluded patients. Looking at our next study, Kramchandani and colleagues had conducted a multi-center retrospective cohort study to determine new persistent opioid use in patients discharged after post-op intensive care with the VA healthcare system. So they looked at 350,000 patients approximately that were opioid naive, that before operation and then post-op were in the ICU for greater than 24 hours. And this was over the course of several years, so from 2000 to 2016. So they also were able to look at changes once there were the publication of the pain, agitation, and delirium guidelines in 2013, which I'll talk about those results in just a minute. What they found is that 4.1% of patients developed new persistent opioid use. So from their cohort of patients, it was only 4% compared to some of the numbers we'll see later on. And I found those that were most likely to be continued and have new persistent opioid use were those patients that were younger, that had alcohol use disorder or substance use disorder histories, which isn't surprising, as potentially they may need or have more addictive personalities and be easier or more prone to opioid tolerance and persistence. The limitation of this study is that they didn't really examine patient or ICU characteristics that might be associated with persistent use. When they did, they didn't count opioid prescriptions that were filled outside of the VA health system as well. So we're not sure, if there were more than 4.1% of patients, if those were patients filling prescriptions elsewhere, and so maybe this percentage is actually higher. And then in terms of looking at their time points from 2000 to 2016, they weren't really able to identify. So they had a few things that changed in 2013. They had the pain, agitation, and delirium guidelines published, but also had rolled out an opioid safety initiative within the VA health system, and so they weren't able to see if there was really an effect between either pain, agitation, delirium guidelines or that rollout. But overall, they had found a relatively low percentage of patients developing persistent opioid use. Our next study, this was an abstract at SCCM presented in 2018, and it was a single center retrospective case control study that sought to identify risk factors associated with receipt of opioid prescriptions at hospital discharge after admission to a medical ICU. This is at the University of Vermont Medical Center, and what the researchers had hypothesized is that patients who were given continuous infusion of opioids, especially for a long period of time or at a high rate, may have a higher risk of being discharged with a prescription for opioids than those who had not. What they found in their population of about 3,000 patients is that opioid naive patients that they included, about 9.5% were prescribed opioids at discharge, and they found when they compared between their continuous infusion opioid group versus not, they really didn't find a large difference in those patients that were prescribed opioids at discharge. It wasn't statistically significant. You can see it was 6.8% versus 7%. And then the big differences in those that were sent home on opioids versus not sent home on opioids were those patients that were mechanically ventilated. They were more prone to have persistent use, those with chest tubes, and those with PEG tubes. Our next study by Wunsch and colleagues had performed a population-based cohort study to determine the frequency of persistent post-hospital opioid use among patients who were mechanically ventilated. Their population included about 22,000 opioid naive patients in the ICU that were receiving invasive mechanical ventilation, and they matched this to patients that were not receiving ICU care, were not mechanically ventilated, to try to compare between the two groups. This was a group from Ontario, Canada, that had conducted this study. Their primary outcome was new persistent opioid use during the year after patients were discharged. They excluded patients that received opioid scripts 90 days before hospitalization. That's what their definition of opioid naive was. And those patients that had an overdose in the past year or as an indexed hospitalization. They excluded those patients of note that were cardiac surgery or admitted to an ICU the year before index hospitalization. So this probably isn't very accurate of a patient population that may have multiple readmissions and the cardiac surgery patient population. They found that 20% of patients filled prescription for opioids in 7 days after hospital discharge, and that about 2.6% of those invasive mechanically ventilated patients had persistent use. What they found compared to the matched group was that there was higher persistent use overall in the mechanically ventilated group versus those that were non-ICU and not mechanically ventilated. And the big factors they found that were associated with persistent use included surgical patients. So being a surgical patient versus a medical patient was a risk factor for continuation and persistent use at discharge. Of note, their persistent use definition varied from other studies. They looked at patients that filled a prescription within 7 days of hospital discharge and then had filled 10 or more in a total of more than 120 days supply within the first year after hospitalization. And then a major limitation of the study was their inability to determine the exact exposure to opioids that patients had during their hospitalization. This study may look familiar from our earlier presentation, but Von Ulrich and colleagues had looked at opioid use after intensive care, and this was the nationwide cohort study in Swedish patients, where they described opioid use after ICU admission and identify factors associated with chronic opioid use after critical care and determine if chronic opioid use is associated with an increased risk of death. So their definition of opioid naive was patients who received no opioids in 12 months before admission, even if one script was filled in the year leading up, they weren't included. They excluded methadone but buprenorphine users and those that had died in the first 2 quarters after admission, since they weren't able to assess their outcomes. And they followed these patients for 24 months, so they were able to follow them for quite a while over the course after their discharge. They found that 10.8% of patients were chronically continued on opioids after discharge. And as mentioned before, those patients that were more likely to be continued on this medication, that included both your opioid and opioid naive patients, were those patients that were female, had somatic and psych comorbidities prior to admission use, a longer ICU length of stay for more than 2 days. And they also looked at lower income and lower level of education and found that those were also factors associated with continuation in all of their patients. So that included both opioid and not opioid naive patients. And then specifically looking at chronic use after discharge in those naive patients, they found that age, being female, having a lower level of education, somatic comorbidities, surgery, and having an ICU length of stay greater than 3 days was more likely to be affiliated with continuation on discharge. Overall, they found that all-cause mortality 6 to 18 months after ICU admission for chronic opioid users was 1.7. And then of note, they found that over time, use decreased by about 4.3 milligrams of oral morphine equivalents per quarter. However, it still remained high at the end of the study at 24 months. their major limitation for the study was that it had been missing some data, but they had deemed that not to pose like a big risk to the results of the study, since their data set was so much bigger. It was so large that they deemed it to not impact that. Moving on to our next study. So academia and colleagues had looked at opioid prescribing after discharge in a mechanically ventilated opioid naive cohort. So this was just no opioid naive patients in their single center retrospective cohort. They sought to determine how the percentage of patients potentially prescribed unnecessary opioids on discharge of their opioid naive cohort. These patients were also mechanically ventilated, which is important to point out because some of these studies didn't all include mechanically ventilated patients, and they excluded those patients that were deceased at the time of chart review or moribund, those that had opioids in the past 30 days, and those with cancer-related pain, a history of fibromyalgia, opioid abuse and dependence, or of note, which was interesting, they had excluded patients that were discharged to rehab, hospice, and LTAC, a long-term acute care facility, or outside hospital. And that was mainly just because of the difficulty and inability to track data and see if patients were continued on opioids once they were transitioned to a different institution. Their patients had to have received continuous or intermittent IV opioid analgesia for at least 24 hours during mechanical ventilation to be included. And what they found was that 45% of patients were discharged with outpatient opioid prescriptions, and 63.3% of discharge prescriptions were in alignment with their 24-hour pre-discharge requirements. And however, 36.7% of discharge prescriptions were in excess of calculated pre-discharge requirements. So at least more than half of these patients were discharged on something that made sense with what they were receiving in terms of their opioid requirements before going home, but one-third nearly of these patients were discharged on higher doses than what they had required inpatient. 57.7% of patients had received non-opioid analgesia, so multimodal pain therapy, which is kind of a low number. We'd like to see a higher number for these patients, especially with the guidelines and standard of practice recommending this. They found that the factors affiliated with increased risk of inappropriate discharge of opioids were those patients that were admitted to the cardiothoracic ICU, and what decreased the risk of inappropriate discharge opioids were those patients that had a shorter duration of inpatient oral opioid therapy. So I think based on this being a single center study, their risk factor was their patients admitted to CTICU, which might not be generalizable to all CTICU patients, depending on your institution. They were also pretty restrictive in the patients that they did include for this study. So, those patients that were on continuous infusion or intermittent during the ICU stay while they're mechanically ventilated kind of cut out a lot of patients they may have included. So it definitely limits the external validity of the study to a general ICU patient population. And also is why they had only 71 patients included in this study. Our next study that we're going to talk about looked to answer the question, is admission to the intensive care unit associated with chronic opioid use? This was probably the most impressive study in terms of follow-up. They followed patients for 4 years at different time points. So they had some longer term data than our other studies that we've talked about. Their objective is to describe opioid use before and after ICU admission and to identify those factors associated with chronic opioid use up to 4 years after discharge. So they included nearly 2,600 patients admitted to the ICU. They were admitted to an ICU in Halifax, Nova Scotia, and they assessed these patients for opioid use at 3 months prior to their ICU admission to determine if they were a non-user or intermittent or chronic user. And then they assessed them at discharge. They assessed them annually for every year for 4 years after ICU discharge. In their patient population, their median age of patients was about 48, so it's kind of low considering the median age of patients in general in the ICU. What they found is that in those patients 3 months prior to admission, out of their whole patient population, about 77% were non-users, about 17% had intermittent opioid use, and 6% had chronic opioid use. In their non-users, they found that those numbers changed. So those patients initially, there were 88% of non-users, and next follow-up at 48 months, 95%. So that basically means that over time, more patients were not using opioids anymore. So they also kind of support that trend that over time, opioid naive patients may have less use of opioids over time. They found that intermittent and chronic opioid use decreased to 8.6% and then 3.6% at discharge, and then 2.6 and 1.8%. So that was the prescribing of chronic opioid and intermittent opioid users. The factors that they found to be associated with chronic opioid use include those patients that had prolonged hospital length of stay, and then they, of note, found that admission to the ICU and the duration of the ICU stay was not associated with chronic use. So their overall hospital length of stay, not necessarily ICU length of stay, was found to be a factor associated with chronic use. Next, Whitcraft and colleagues conducted a single-center retrospective cohort study to characterize opioid prescribing practices across 2 different transitions of care during an inpatient hospital stay. They included opioid-naive adult patients who were started on opioids in the MICU or IMC, and they looked at patients at these 2 different transition points. So patients when they were transferred from the medical ICU or the intermediate care unit to the floor, and then also those patients that were transferred from the floor to discharge. So they found that in their group of patients from MICU IMC to the floor, opioid continuation was about 56%, and then on the next transition of care from the floor to discharge, opioid use continuation was about 56% at that point in time as well. They broke down based on the transfer stage, so those patients transferred from MICU or IMC to the floor. They looked at the characteristics of those continued versus not continued on opioids and found that a longer hospital stay is what influenced patients being continued on opioids when they were transferred to the floor. When they were transferred from the floor to outside of the hospital, they found that intubation during hospital stay was a risk factor for continuation of opioids, and that cumulative opioid dosages being higher was also a risk factor for patients being continued on opioids. I guess a limitation of this study is that they assume that opioids were continued intentionally by the medical team, so there's no data to really influence like if the continuation had been just an overlooking of orders or if it was intentional for a true treatment of pain in these patients. But that is just kind of the nature of being a retrospective study. It's going to be hard to parse out that information. Next study that I wanted to talk about was the impact of opioid administration in the intensive care unit and subsequent use in opioid naive patients. So this was a multi-center retrospective cohort analysis to evaluate the relationship between ICU opioids administration to opioid naive patients and then subsequent opioid use following discharge. In their cohort, they included opioid naive patients receiving continuous infusion IV fentanyl, hydromorphone, or morphine. And they included those patients that were admitted for over 24 hours with a primary, so they included those patients that were opioid naive and found that in patients at discharge, they found 47% of patients received opioids. So this is closer to that number of 56% reported in the previous study. And they found that 5% of patients became long-term opioid users, and this was more common in those with opioids prescribed at discharge. So this was statistically significant with a p-value of 0.006. They found that neither total ICU milligrams of morphine equivalents nor daily equivalents correlated with daily equivalent quantity at discharge, which was interesting to see. And they found that predictors of opioids at discharge included those patients that had a history of illicit drug use, although they were opioid naive at the time of inclusion, those patients that had a longer non-ICU length of stay, those patients that had admission diagnosis of respiratory, surgical, neurology, trauma, or malignancy. So this varies from the previous studies that I've talked about that may have excluded patients that were admitted for malignancy as well. And I accidentally skipped this study. So going back to the, Johnson and colleagues, they looked at opioid prescribing at discharge in opioid naive trauma patients specifically. And this single center retrospective cohort study looked at patients that were admitted specifically for a trauma injury. They included 470 adult opioid naive patients that had been admitted for trauma for greater than or equal to 24 hours. They found the mean age of these patients was 60 years, with 62% being males, and that the majority of blunt trauma were blunt trauma and falls rather than penetrating traumas. And they found that 93.6 received non-opioids and 84 received multimodal analgesia, which is a great number to see compared to the previous study that reported much less multimodal analgesia. This is a more recent study as well, so perhaps as practice changes have happened, multimodal analgesia has been used, and this study kind of shows that at this center, their practice is to use quite a bit of multimodal analgesia. Their ICU length of stay was about 0 to 4 days, and hospital length of stay was 5 with a range of 3 to 9 days. So relatively short hospital length of stay compared to maybe some of the other trials we've talked about. They found patients prescribed opioids in the hospital with 70.4%, and at discharge, 39.4% were prescribed opioids. What they found is the patients that were less likely to be discharged on opioids were those that were over the age of 30, that were admitted to the ICU. So what I didn't mention is that this trial included patients that weren't necessarily admitted to an ICU. They're admitted to the ICU or trauma acute care floor, so not all critically ill, which makes this less easily comparable to the other trials that were more ICU focused. One of the limitations they noted was that they didn't evaluate the number of opioids, cumulative doses, or duration. This is similar to many of the other studies, but they did find that compared to previous literature, only about 40% of patients were discharged on opioids, which is lower. However, this is the first study to really look at an overall trauma population to assess this. Moving on. All right, so to compare the existing literature, so after I've gone through all of the studies, what does all of this mean? What does this find? So I created this table here to kind of show kind of a summary of what this means. So we found the factors that were affiliated potentially with increased opioid prescribing in a few studies included ICU admission or length of stay. The longer it was, the more likely patients were to be prescribed opioids. Academia and colleagues found that CTI ICU admission itself would be affiliated with potential continuation of opioids at discharge, which is in contrast to the Johnson trial, which I just discussed in trauma patients that found ICU admission or length of stay had led to a decrease in opioids. So it's unclear as to being in the hospital longer, is that going to make it that you're less likely or more likely to be prescribed opioids? Potentially, some could argue that while you're in the hospital or ICU, there's going to be more monitoring and better follow-up for discontinuation when appropriate in those patients. However, some trials have found that that's not the case, and the longer patients are in the ICU, the more likely they are to be discharged on opioids. Of the studies that looked at invasive mechanical ventilation, they found that there was an increased risk with being ventilated, with having opioid continuation on transitions of care. And then higher opioid requirements is also questionable as to if this causes an increase or decrease in prescribing from the hospital. So does being on more opioids while you're in the hospital increase or decrease? I think that remains unclear as well, since there are 3 trials that show differences and everything, and they were very heterogeneous overall. So making a comparison is very hard, and it's hard to say either way that these are all definite risk factors or not. So kind of looking back, what are the potential risk factors for opioid continuation after ICU? Potentially prolonged non-ICU length of stay, but again, that's controversial. We do know prior to admission use, so in those studies that included both opioid naive and patients that were opioid users, those patients that used opioids before they came in were more likely to continue using them on transitions of care, which makes sense. And then, as I mentioned before, the mechanically ventilated patients were more likely to be continuing on opioids after the ICU. So moving on to our next audience response question. Admission to the ICU is a definite risk factor for continuation of opioids on discharge from the ICU. Right, exactly. So it remains unclear as to whether admission to the ICU is a definite risk factor for continuation of opioids on discharge. So the answer to this question is false. So I kind of alluded to some of these gaps in the literature. There's a lot of heterogeneous data. The critically ill patient populations that opioids on transition of care have been studied in is pretty heterogeneous, since there are so many differences between our patient populations in the ICU. And we still don't have a great idea of what consistent risk factors for an ICU population are going to increase the risk for opioid continuation upon discharge from the ICU and the hospital. So maybe the answer here is it's in the transitions of care and not just the ICU. So what can we do along those points where the patient's transferred from the ICU to the floor, to home, or to another facility? At these points in time in transitions, we don't have a lot of great follow-up in terms of pain assessment, especially after discharge from the hospital. So when patients are discharged from the hospital, it's not like patients have a great pain assessment tool that they're using at home. They're in pain, they will take their medications, and if this doesn't get followed up after discharge, then patients will be continued on these medications that have an increased morbidity and mortality. And then opioid exposure and acute pain may potentially lead to chronic pain, and this might have a role in post-intensive care syndrome. So the post-ICU clinics are a place where perhaps we can follow up with these patients and see and reassess their opioid use, and from there be stewards of opioid use at that point in time. So now that we've discussed some of the literature regarding opioid use across transitions from the ICU, I wanted to discuss some opioid reductive strategies and helping us be judicious about using opioids in the ICU. Big thing, as I mentioned before, is having accurate pain assessment and being judicious and evaluating the need for continuous infusion opioids. This is something that our institution has looked at. Just because a patient's in the ICU and intubated doesn't necessarily mean they all have the same fentanyl requirements and need a fentanyl infusion going. So kind of reassessing and seeing if you can use PRNs for those patients or as needed medications for those patients while still making sure you are adequately treating their pain. And then making sure to adjust opiates to symptoms. In the ICU, we can constantly every day reassess, is this patient still in pain? Do we still need these agents? Can we optimize these agents for these patients? And can we add on multimodal pain medications? Are there non-pharm pain management things that we can do to help decrease these patients' pain while also potentially decreasing their opioid use? Something else that would be helpful is an opiate withdrawal assessment, and I'll talk about that a little bit later. And then counseling patients, discussing with them their pain and trying to understand their pain control and optimizing that for them. Additionally, reevaluating opioids during transitions of care, as I mentioned before, and having post-ICU clinic pharmacist involvement may be ways in which we can reduce opioid use, especially at these transitions of care. So we've talked about pain assessment before. So again, making sure that we've got a good pain assessment plan for patients using validated tools for ICU patient population to assess their pain is important. And again, as mentioned before, multimodal pain management is important. So using those agents like acetaminophen, ketamine. If patients have neuropathic pain, gabapentin or pregabalin or carbamazepine are options. Potential nonsteroidal anti-inflammatory drugs. And then lidocaine, as mentioned before, has toxicities associated with its use neuro and cardiac, so kind of maybe using that, but the guidelines don't strongly recommend using lidocaine, so it's questionable if that will work. But it's lidocaine patches or maybe something you could consider for multimodal pain management. And then non-pharmacologic pain management, as mentioned before. Oh, I'm very sorry. Don't know what just happened. Non-pharmacologic pain management, so that massage therapy, music therapy, cold therapy, and relaxation therapy are potential options to help decrease opioid use and pain. And then, as I mentioned before, so having a good way to assess for opioid withdrawal. This is a part of the literature that's lacking for critically ill patients. We don't have great specific tools for adults that have been validated. There have been tools for critically ill pediatric patients that have been looked at and potentially tried to be validated for adults, but have not panned out. So there's a withdrawal assessment tool that has been looked at, however, isn't validated for adult critically ill patients. So management for opioid withdrawal kind of varies as well. Many institutions don't have specific protocols to manage, so they don't have, so it's oftentimes a gradual weaning of opioid, but no specifics on how to gradually wean that opioid or reintroduce previously weaned opioids, or using alternatives to these agents. So when these patients are potentially going through withdrawal, managing these is important. And then another option for potential withdrawal is looking at methadone or alpha-2 adrenergic receptor agonists, where we've had more data for these agents for withdrawal in pediatric patients, but are also options to consider for your adult patients too. So going into our last audience response question, which of the following are potential opioid reductive strategies that can be used for ICU patients? The options are consistent pain assessment, multimodal pain management, opiate adjustment to symptoms, and involvement of a pharmacist across transitions of care. Yeah, so all is the correct answer. So making sure we've got consistent pain management, multimodal pain management, opiate adjustment to symptoms, and involvement of pharmacists across transitions of care may all be potential reductive strategies that can be used for our ICU patients while in the ICU and as they're being transitioned out. So in conclusion, pharmacist integration into opioid stewardship programs, specifically geared to ICU patients, may ensure judicious use of opioids in the ICU. Our opioid stewardship programs aren't specifically tailored for ICU settings, for the critical care settings. It's more so in terms of hospitals and healthcare systems. So we don't have a lot of great data. And it's unclear what effect starting opioids in the ICU may have on long-term continuation, as I alluded to in question 2, and the audience response is that we don't really know, and we don't have great data saying that starting an opioid in the ICU means that you'll be continued on it longer term, as we talked about in the literature. And then efforts to reevaluate the use of opioids on transitions of care and utilization of opioid reduction strategies where appropriate can be taken. With that, last remarks. So moving forward, as I mentioned, opioid deaths have been increasing, and it's unclear too the impact of COVID-19, especially with sedation strategies and analgesia strategies, where perhaps when patients are critically ill and on the ventilator, we're using higher doses of medications for a longer period of time. So these patients might be continued on opioids for higher doses for longer periods of time on the outpatient setting or once they're discharged from the hospital. We don't have a great idea of what specific risk factors exist for prospective screening, but that trial from Sweden had one of the largest patient populations and might be a starting point for risk factors for prospective screening for patients to identify who might be those patients that are more likely to be continued on opioids when they leave the ICU. There's a lot of work that can be done with medication-assisted treatment, as looking at the current state of opioid stewardship programs. This is an area that we can definitely improve on. And then specific strategies for pain control in the ICU have limited evidence as well. So, you know, this is also just kind of a limitation of the data we have and something to consider moving forward. That being said, I'm all done and happy to take any questions if we have time.
So I think similar to before, if you have questions for Dr. Landolf, please refer them to the NYSCHP office. We will get in contact with her and get your questions answered that way. Again, I wanted to thank Dr. Landolf and Dr. Moore for their great presentations tonight and for helping us facilitate this webinar. I will get into the CE codes for this presentation. So the CE code for pharmacists is Stewardship, and the CE code for technicians is Element. Again, the CE code for pharmacists for this session is Stewardship, and the CE code for technicians is Element. And you should be receiving an email in approximately 1 week with links to obtain your CE. And if you do not receive an email, please contact the office at ceprograms@nyschp.org. And again, I want to thank our speakers one last time and all of you for attending and making this webinar series a success. Thank you.